improvement project. Learning objectives, hopefully we'll talk about the importance of screening, prevalence, and diagnosis of neurocognitive disorders, cognitive impairment, critical evaluation of screeners, comparison of screeners, and recommendations. So the importance of screening, obviously cognitive decline is one of the leading causes of functional impairment among older adults. So screening for these deficits and early identification is important. Identifying patients facilitates appropriate treatment, of course, and referrals by clinicians, and it allows clinicians to work with families and the patients to come up with an appropriate treatment plan. Worldwide dementia, there's approximately 55 million people with dementia, which is expected to rise to 78 million in 2030. The total cost of dementia was about $1.3 trillion in 2019, and that's worldwide. Here in the US, it's almost 6 million people in 2019 and almost 9 million in Europe overall in 2018. So specific risk factors for the development of neurocognitive disorders, obviously age is number one. As you age over the age of 65, our occurrence of development of neurocognitive disorders doubles every 5 years. Also, if you have development of mild cognitive impairments early on, that is another risk factor, as well as certain psychiatric conditions. Polypharmacy is another one that's been researched, 5 or more medications, or those anticholinergic medications. Substance use, repeated or severe traumatic brain injuries, having lower SES or limited education, as well as other serious and chronic medical conditions such as cardiovascular disease, put individuals at increased risk. So getting it right each year, there's thousands of misdiagnosed, and correct or misdiagnoses can create harm for patients and unnecessarily expense, lead to inappropriate treatments or missed opportunities for treatment. So sometimes it's not a neurocognitive disorder. So as clinicians, we have to be aware that there's other factors that could be contributing to the presentation of cognitive impairment in our patients, such as delirium, some kind of infection going on, depression called pseudo-dementia for a reason, what psychiatric conditions could be happening that could be contributing to these complaints or this presentation, as well as medications, nutritional deficits, other chronic medical conditions, substance use, or even vision and hearing deficits. So 5 physician factors contributing to missed and delayed diagnoses. So in this study, it looked at what kind of led physicians maybe not to diagnose appropriately or on time, and it was educational needs was one of them, not being able to detect or diagnose, concern about consequences of misdiagnosis, attitudes towards dementia, the stigma or the limited treatment options, their familiarity with testing for dementia, knowing what to do, and then how to communicate that to the patient, disclosing it or explaining the diagnosis. So the different neurocognitive disorders, as I'm sure most of us know, have different presentations and different deficits that arise and in different orders. So this is just a brief overview. I won't go through it, of the different types of dementias and the different things that we may see surfacing early on. So when we're thinking about screening our patients for cognitive impairment, we want to think about what domains we want to tap into. And it would be great if we could hit a screener that taps into all the main cognitive domains that are impacted by the different types of dementias, right? So executive functioning, visual, spatial, language, naming, processing speed, attention, memory, both short and delayed, abstraction, motor skills, and their orientation, which we generally gather through a mental status exam. All right, so looking at different screeners, we want to say, okay, which ones tap into what can be helpful here? So it's important to critically evaluate screening tools. We want to use ones that are valid. We don't want to use ones that aren't going to give us the answers we need or mis-screen people because we don't want to miss these diagnoses or delay the treatment. Some of the readily available ones, at least here in the States that we use, is the Montreal Cognitive Assessment, the St. Louis, Missouri Mental Status, and the Mini Mental Status Exam. The MoCA specifically taps into all those cognitive domains I mentioned just a little bit ago, and it in one study showed to have 100% sensitivity and 87% specificity, and the MoCA has been around for a while. And seems to have a lot of research to support its utility in clinical settings. And I'll talk a little bit more about that in a minute. All right, so here is just some tables taken from the clinician's review that was done in 2013 of different cognitive screeners and what they're looking at, how long it takes to administer, and their sensitivity and specificity. We are going to focus on the MoCA because it's so widely used in research. And when I talk about this comparative study in a little bit, that is why we chose the MoCA in comparison to another device I'm going to talk about, which is the Cognivue, a newer technology for screening for cognitive impairment in older adults. So the MoCA, many of you have seen this before. It used to be free in the public domain. Now there is training required because they want to standardize the administration. So you do have to pay for that now. I'm not sure exactly how much it is, but this is what the MoCA looks like. It was free at the time that we administered this. It's 30 questions, about 10 minutes to administer. The clinician needs to administer it and or someone that's trained to administer it properly. And again, the clinician will obviously have to interpret that for the patient. There are the areas measured. It is available in alternative forms. It has numerous languages translated into, which really makes it helpful. And then a score of 26 or higher is considered normal and no sign of cognitive impairment for the strainer. A newer device, what was newer at the time, it's been out for several years now, the Cognivue is a screening device. It was developed to screen for cognitive impairment. It's a standalone machine. There's a little wheel you can see there in the center of the picture. You turn that wheel in order to select your answers. Stimuli is presented on the screen briefly, and then the participant is asked to spin the wheel to select the item that they want to match. It is an FDA clear device. What that means is it is a device. There's nothing to compare it to. It's new, and it doesn't seem to pose any immediate injury or threat to an individual as long as it's used in the way it's supposed to be used or the way it's prescribed. There's 10 tests that are administered in about 10 minutes. No clinician time is needed for this, which makes it very appealing. More information about it can be found on their website. So the Cognivue says it measures areas similar to what the MoCA measures. It says it calibrates for motor and visual. I'm not sure exactly how it does that. There's no adjustment for education level, and a score of greater than 75 is considered normal. Underneath that is considered some level of impairment. So on the Cognivue, this is, I took chunks of this bigger report that they give. This is kind of the top of that report. So it gives you a very nice report printout. They may have changed it. Again, this was done a few years ago. This one was printed in 2018, and they had changed it when I printed this one. So they may have another one by now, but it gives you an average score. It outlines the different domains it measures, what subtests of those 10 go under each of those domains. And it kind of just breaks it down and gives you the scores. The report looks very nice. At the time that we did this study, there was one peer-reviewed and published article, Hidalgo, and we had some questions regarding their conclusions and findings as we started to look at this more. They had done comparisons with the Cognivue and the slums, as well as some other neuropsychological measures that they had compared it to say if it had some correlations. And it didn't seem like their neuropsych tests were administered by neuropsychologists or psychologists. The correlation with Cognivue, they described them as components, really wasn't clearly defined. They indicated there was some high correlations between the Cognivue and a few of the neuropsych measures and the slums, which is the St. Louis, Missouri screener that I mentioned earlier. But most of the correlations were low to moderate. Cognitive domains measured by Cognivue weren't really well defined in this research study, and there was, again, only one study, so very limited research, and this research is also funded by the company, so the results can be a little maybe biased. The Cognivue profile highlights a memory component, so after initial exposure of the visual stimuli, like I mentioned, it flashes on the screen, then the individual is asked to select what item they saw. So there's a brief delay there, which can be considered short-term memory, but really not a long-term memory process. It's a pretty brief delay before the individual is asked to recognize what they saw. Recognition of stimuli in a multi-choice format is easier than free recalling or encoding stimuli into long-term memory. So for some individuals with neurocognitive disorders, recognition can be intact for some time before. So this could lead to false negatives, potentially presenting all the information of the subtest this way. the language component. So in the article, they indicated there's a strong correlation between the slums and the Cognivue language, but there's differences in the way these tasks are given. So the naming task on the slums is verbally generate as many animals as you can in 1 minute. It's intended to screen for aphasias or other languages disturbances. But on the Cognivue, there's no verbal component. They visually present either letters or simple 3-letter words, and then the individual is then asked to select what they saw. So this involves some elements of language, but it doesn't assess the same area of the brain as naming tasks that require that verbal fluency or that word finding skill, which are common deficits in disorders like Alzheimer's disease. So there may be a correlation there, but they're really not tapping into the same areas of the brain that we want to see assessed when we're screening for neurocognitive disorders. So advancements in cognitive screening, obviously very exciting. Aside from the Cognivue, there's other ones. The historical clock drawing test has been turned into a digital version as well. So these tests show promise, but we don't want to put the cart before the horse. We need to make sure that there's plenty of research, sample sizes, that these things are unbiased, and there's evidence to support that these advances in technology are measuring what we want them to measure, because we don't want to misdiagnose patients, because it does cause distress. So the comparison study we did, where in an adult mental health outpatient clinic, we're attached to the hospital, but we focused on adult psychiatric outpatients. So every patient had at least one psychiatric condition or more. We chose individuals 55 or older. We asked them to participate. We gave them both the Cognivue and the MoCA, and we collected other information in their charts. So the ranges was 55 to 89 years old, majority female, majority white, a majority had 12 years or more of education. So on both of these, for both of the screeners, they identified 16 of these subjects. So we had 58 participants. And so 28% of those subjects were identified as negative, no cognitive impairment. So 16, the MoCA and the Cognivue agreed. They did not screen positive for cognitive impairment. So then on one or both of them, 72% of the sample screened positive for some cognitive impairment. So the majority of participants, 42. Of those 42, 43% agreement between screeners in identifying. So about 18 of the 42 participants were identified by both screeners as having some impairment. But then each, the Cognivue and then the MoCA, each identified 12 separately as being positive for cognitive impairment. So we wanted to look a little bit closer at the difference, the MoCA identifying 12 and then the Cognivue identifying 12. We see that some of the demographic differences, education was about the same, the differences kind of in their score. We see with the ones that were positive just on the MoCA, they were all female, and the sample was a little bit older than the ones that only screened positive on the MoCA. If we look at the MoCA, the score is really close to that 26 cutoff. So that could potentially be some false positives if we're not watching where that cutoff is and paying attention to where those people are scoring. So given all the differences with the scores, we looked at all the different subtests of the MoCA and the Cognivue. Now this chart table was very large. I just picked out the couple that showed some kind of low to moderate correlations between the subtests, but there was mostly very little significance with correlations here between the MoCA and the Cognivue, aside from these few. And again, this table was quite large. But it did show some low to moderate correlations with visual, spatial, naming, and attention. But again, most subtests did not correlate. So conclusions of the study, the Cognivue subtest to appear to place cognitive demands in the following domains: visual ability, motor control, attention, processing speed, visual discrimination, short-term memory, and recognition. Deficits in one or more of these domains may impact a participant's performance on a lot of the Cognivue subtests due to the way that they are structured. Subtests do not appear to assess long-term memory, executive functioning, language, or abstraction, and it's important to clearly define Cognivue subtests to determine its efficacy as a screening tool. So more unaffiliated research is needed with larger sample sizes. limitations of our study, it was a psychiatric outpatient sample, so this really limits our generalizability of some of the data, and the sample size was small, it's only 58 people. So this limits our interpretation of these results. This was my wonderful project team that we all worked together on all of these materials in the study. So recommendations overall from all of this. So practicing clinicians should be aware of the importance of identifying cognitive impairments among older adults. Screening tools may play an important role in the identification of cognitive impairments. So they should not be seen as an inconvenience or something that, oh, this takes too much time, because I know we're all pressed for time when we see our patients. But this is an essential part of optimizing our patient care, especially when we're treating a lot of older adults. A cognitive screening tool should be chosen because it is efficacious, not because it's new and easy. At this time, we recommend the MOCA, despite the additional time and training it requires. Also, there are some other brief screeners that would work as well. We think that the Cognivue maybe needs to be put on hold, and other new screening tools like it, until there's more research to support exactly what it's measuring and that it's reliable and valid. So key takeaways, inadequate evaluation and misdiagnosis of neurocognitive disorders have consequences for patients. It causes anxiety, distress, inappropriate treatment, expense. So we need to be using valid and reliable screeners. Do not use screeners as diagnostic tools. Again, they're just screeners. It's just an indication of, hey, something might be going on here, but we need to dig deeper. We can see collateral information from individuals who know the patient well, the patient themselves, but also like a close family member, a spouse, a child. We want to make appropriate referrals as needed. So if someone screens positive, we need to refer, say, neuropsychology or psychology, neurology, a geriatric specialist. We need to take a look to see, like, okay, is this present? We need to rule out things that could be contributing, like a delirium, like vitamin deficiencies or polypharmacy. And as clinicians, we shouldn't be practicing outside our scope. If we don't feel comfortable screening, refer out, and always seek consultation and continuing education. So lots of references here, and that's all. If there's any questions.